It's very nice to be in Athens, and Greece is a wonderful country. So today I was charged with the antegrade and retrograde recanalization of the ureter. And when I was charged with this, I was a little bit nervous because my knowledge of this topic was limited, I felt. So the first thing I did was I searched the literature, and simply typing endoscopic ureter and stricture into Google only brings up 700 abstracts. I went through all those and I kind of distilled it down to 10 good papers. In those 700 papers, there's only one randomized controlled trial, so the quality of the evidence is limited. What I will state from the start is that endoscopic management of a ureteric stricture is less successful than open laparoscopic or robotic surgery, and it is likely more expensive. Things you need to consider, which will become apparent at the end of this talk, is the stricture size and location, which method you use to dilate or cut the stricture, and the stent size and duration of that. So just to classify strictures, a ureteric stricture can be intrinsic or extrinsic, and if you're going to do an endoscopic management, you should solely focus, I believe, on intrinsic strictures. And you should focus on benign. Malignant strictures should not undergo this management, and extrinsic strictures are not suitable. And another classification of a benign stricture is if it's vascular or ischemic or non-ischemic. And non-ischemic stricture would be one which may have resulted from an impacted stone or congenital abnormality. And this is the area you should focus on if you want to endoscopically manage a patient. So again, when you're faced with a patient, the things you're going to consider is, will I balloon dilate this? What size balloon and what pressure and for how long? Will I cut it? Will I cut it with a cold knife, hot knife, or will I use a laser? Will I do a combination? And there's some decent evidence for these. When it comes to stent size and stent duration, the evidence is not as good, even though there is a randomized controlled trial with regard to that. So just with balloon dilatation, there's this meta-analysis from Lou, which came out in the last 3 years. 19 studies with 683 patients, so each study was quite small, and they followed the patients up at 3 months and at 5 years. And they included benign and malignant short and long strictures. And the short-term success rate as patency at 3 months was 60% plus or minus 10%, and long-term success rate at 5 years was 54% plus or minus 14%. When you look more closely at the studies included in this meta-analysis, we can take this one by one. They had benign and malignant strictures, only 37 patients, and they dilated for 10 minutes at 2 to 18 atmospheres, a very wide range of balloon dilatations, and they placed 7 stent French for 3 weeks. And their outcomes were not good. 7% of benign strictures were patent, and 14% of malignant strictures at 36 months. One of the things they noted was that if a stricture is greater than 2 centimeters, the success rate is 0%. Looking at optimal balloon size and pressure, the evidence for me to give you that is, it's hard to know. This study by Corcoran from 2009, they used a 15 French balloon at 14 atmospheres for up to 10 minutes, and then a 6 or 7 French stent for 6 to 8 weeks, and their success rate was 85% for short non-ischemic strictures, while Richter, 9 years earlier, used a larger balloon at 2 atmospheres for 90 seconds, and then a 7 or 8 French stent for 4 weeks, and their success rate was 89%. So the balloon size and pressure we don't know what's best. I do a few of these, and what I think is best when you're doing a balloon dilatation is that when you initially start to inflate the balloon, you'll see a waist where the stricture is. And you're not done dilating until you see that waist disappear, and you've properly treated the stricture. And that's the one and only tip I can give you. When you look at the pressure gauge, you will see that it is, if you set it to 14, you will see it drop, and that's because the stricture is given, and then you can bring it back up to 14 again for the duration of which you like. If you're not into balloon dilatating, you can do an endoureterectomy. We all know this is a full thickness incision. Posterior laterally, if it's proximal or anteromedial for distal strictures, and you can use a cold knife, diathermy, or laser. I think most people nowadays use a laser fiber. And there's a few big papers in the endoscopic management of strictures, and this one by Hafez and Wolf reported success rates of 60 to 86% with endourethrotomy. One key point in that study from those authors was that if the split function of the kidney is less than 25%, the success rate of endoscopic management of stricture is 0%. Laser endourethrectomy outcomes. This study by Nissen et al. Just 35 patients with benign strictures. They followed them for 27 months. They used a 550 holmium laser fiber. And they had good outcomes, 82% symptomatic improvement and 79% radiographic improvement. And again, the short strictures, which were non-ischemic, had the most benefit. If you don't have access to a laser, you can use a cold knife or diathermy as well, and good success rates are reported. However, which is quite different to other studies, is that mid-ureteric strictures treated in this way don't do as well as proximal or distal strictures. This older study from Thailand compared cold knife endourethrotomy to balloon dilatation, followed by a 7 French stent for 6 weeks, and they found that incision was better than balloon dilatation. The question now that most people have, what about stenting? How big should the stent be? How long should you leave it for? And I don't know. After going through all this data, I don't know. Success rates of greater than 80% have been reported with a 6 French stent for less than 6 weeks, while other papers have shown similar success rates with larger stents for longer. The only randomized control trial that I could find was this one by Ibrahim et al. And they compared a single 7 French stent versus 2 7 French stents for 8 weeks in patients who had undergone laser endourethrotomy and balloon dilatation. And they found quite a big difference between a single stent and a double stent. This is something which came out in the BJUI towards the end of last year, and it's from some Chinese authors, and they called it urethral bypass. I've changed the name to endoscopic urethral bypass because there's other ways to bypass the urethra. And what they did was to create a channel, they used a holmium laser set at 1.1 to 1.3 joules and 30 hertz. They created a channel, and then they passed the balloon through that. They used an 18 French or 21 French balloon, and they inflated it to 20 atmospheres for 3 minutes. And then they placed an allium stent, and their success rates were 92% at 12 months. And of course, they're going to be good because there's an allium stent in there. In the paper, they didn't describe when they're going to remove the stent or leave it in. It's hard to know if their failures, which brought it down to 92%, was due to failure to place the allium stent or migration. So this is another paper which came out last year, and this is can we predict who will fail endoscopic management of a ureteric stricture? And it was again from authors from China, and they had 321 patients, of which 85% had benign ureteric strictures, and they followed them up for a median of 590 days, and they looked at their 1, 3, and 5-year stone-free survivals, and well, you can see with the graphic on the right-hand side of the screen, you can see a scoring system. So if it's benign, you get 0. If it's malignant, it gets to 80. The balloon size, a very large balloon of 30 French was associated with a higher score and an increased rate of failure. Presence of nitrites in the urine, which would be, again, suggestive or predict a urinary tract infection, will increase the chances of failure. Chronic kidney disease, so this goes back to that paper from the early 2000s, which showed that if a split function, if the kidney has a poor split function, their success will be poor. Stent retention time, I read this as the time from diagnosis or the time the patient has a stent till you intervene. If this is short, the outcome will be better. And then you can, if you want to use this, you can tot up your score and then see what the 1, 3, and 5 year survival rates would be. So summary, just at 10 minutes now. So going through all this information, I think if you want to pick a patient who's going to have maximal benefit from endoscopic retrograde or antegrade management of a ureteric stricture, you should pick a short, less than 2 centimeter benign non-ischemic stricture, probably related to an impacted stone or something congenital. It should be proximal or distal. The kidney should have a good split function, greater than 20%. If you're going to make an incision, make sure it's full thickness. And if you want to balloon dilate, use a 18 to 24 French balloon. I can't tell you for the pressure in the balloon or for how long. And my final point is, it seems that if you intervene quickly from time to diagnosis or leave them with a short time to intervention, the outcomes will be better. And thank you.